We'll move on to hear from Dr. Sulaiman, you're online. So Dr. Sulaiman's an infectious disease consultant working in Malaysia, who is a current PhD candidate studying antibiotic optimization in patients with sepsis and pneumonia, and is going to be talking to us this evening about how to navigate and optimize intrapulmonary antibiotic pharmacokinetics in ventilated patients with pneumonia.
So my name is Helmi. Thank you for the invitation. So this is the topic that I'll be talking today. So I don't have any much disclaimer except for the fact that I'm not expert in PKPD, and I draw inspiration heavily from these papers and presentations. So this is the outline of my talk. I'll be talking about infection sites in pneumonia, as well as followed by sampling sites for antibiotic in pneumonia. And I'll touch a bit on the possible issues and challenges with these sampling sites. And I'll talk more on ELF sampling and how we can measure ELF antibiotic concentrations, and finish it up with possible challenges when navigating the pharmacokinetic data for pneumonia. So I would like to start with the site of infection. So as Prof. Charles said just now, in pneumonia, the primary site of infections are in the lungs. Specifically in the distal bronchial trees and alveoli. So this, as you can see, this is the blown up structure of a lung unit. So the infection primarily occurs in this area, the alveolar space. So this is where the infection occurs, and we should be concentrating or measuring the blood level in this space or from this area. So the pathogens are usually found in activated macrophages when we are talking about intracellular infection. But when we are talking about strep pneumoniae, the infection is usually extracellular. So it can be found in this blue fluid here. This is called ELF, or epithelial lining fluid. This is where we want to know the concentration of antibiotic at. So in terms of the possible sampling site to assess antibiotic PK in pneumonia, there are few sampling sites that have been studied and reported before or currently too. So the concentration can come from sputum secretion, bronchial secretion, ELF, alveolar macrophages, whole tissue homogeneate, and lung tissue biopsy. And let me touch about the issues with sputum and bronchial secretion. Is it a good matrix? Both of these secretion or sampling sites have been studied and used extensively to characterize antibiotic concentration. However, when you're talking about saliva concentrations, it may underestimate the antibiotic concentration due to dilutional effect of saliva, or it can also overestimate antibiotic concentration because of the high distribution of some antibiotics into saliva or bronchial secretion. Nonetheless, in patients with tracheobronchitis, bronchial secretion might be the optimal metrics for PK study in these patients. How about tissue homogeneity? Is it a good matrix? In order to understand that, we need to understand how we actually come out or assess this antibiotic concentration in tissue homogeneity. The process involves uniformly breaking down or crushing the tissue to disperse the tiny fragment evenly throughout the mixture. And by doing that, you can actually imagine the antibiotic from the intercellular compartment and extracellular compartment then will actually join together. So if you report antibiotic concentrations in this way, you will actually have concentration of both intracellular and extracellular compartment. Therefore, if your aim is to look at intracellular concentration of antibiotic or extracellular concentration of antibiotic, you will overestimate the concentration of the antibiotic using this matrix. And additionally, when we are talking about tissue lung biopsy, this requires an invasive procedure to obtain the sample. Therefore, studies related to this method or this metric is very limited because of the invasiveness of the procedure. Therefore, most of the study, a lot of study currently are focusing on ELF and alveolar macrophages, and they are being said as the current preferred metrics or compartment for the measurement of the drug's concentration. So in order to understand the concentration of antibiotic from the ELF, we must understand how the antibiotic reach this area or these sites. So this is a schematic representing the blood and A barrier. So the antibiotic molecules move from compartment A to compartment B. So you can see that the barrier is made up of capillary wall, the interstitial space, and the alveolar epithelium. So in order for the antibiotic to reach this ELF, they need to actually traverse through these 3 layers or 3 barriers. And alveolar epithelium here is less porous compared to capillary wall. Therefore, if you read studies on hydrophilic antibiotics will have a lower concentration in ELF compared to the plasma concentration because of these barriers. Okay. And how do we sample ELF in a patient or in healthy volunteers? There are multiple methods that can be used, but usually it involves 2 primary methods, which is bronchoscopy or mini bronchoalveolar lavage. So the procedure involves passing a fiber optic bronchoscope or mini valve and wedge this at the middle or lower lung lobe. After that, the valve is performed. And what happens is that during BAL, installation of 3 to 4 aliquots of sterile normal saline solution into the lung lobe will be done. And you should not dwell that fluid for long. It should be immediately aspirated. Then the concentration of the antibiotic will be measured. But as you can imagine, if you do BAL, the recovered BAL is a combination of cellular components, saline and ELF. But we only want the concentration of the antibiotic in the ELF. So how do we then correct the recovered BAL so that we can know the apparent volume of the ELF? This is estimated by using urea, because urea concentration in both plasma and ELF are usually similar. So in order for you to actually know the apparent volume of the ELF, you need to measure the concentration of urea in both BAL and urea, and use these two formula here in order to get to the apparent volume and measure the concentration of the antibiotic in the ELF because of the dilutional effect of the saline. So after measuring that, you will have the concentration in the blood as well as in the ELF. And from there, you can then measure or develop this 2 compartment model. So here is a schematic of the compartment model. So the drug is injected into the blood or ingested by the patient. So you measure the blood concentration. And after that, you measure the concentration of the antibiotic in the ELF. And you will then tabulate this data point to come up with the concentration time profile curve. So from there, you can know that how much of that antibiotic penetrate the lung from the plasma. And in this graph, you can see that there are 18 sampling points within a single dosing interval for both blood and ELF. So I want to move on to what are the issues with the ELF sampling. So this is the first issue with the ELF sampling. Because putting into perspective, say that this is ceftriaxone, that is dosed every 24 hours, we would need to perform BAL 18 times to create this graph in a patient. But in the real world, we cannot do this because we are limited by the number of samples we can perform within a single dosing interval. So a lot of data out there in terms of the PKPD or the ELF data is based on this very limited time point to characterize the penetration of antibiotic from the blood to the plasma. And the second issue is that it is difficult to predict ELF penetration based on physiochemical properties of an antibiotic, meaning even when you're actually talking about the same antibiotics within a same class, for example, cephalosporin, there is a diverse ELF to plasma ratio. There is a diverse penetration ratio of the antibiotic coming from the blood into the plasma. For example, corticobiprol, the ratio is 19%, ceftazidime is 20 to 30%, but in cefepime, one paper reported that the penetration is up to 100%. So this is the same molecule, somewhat same molecule, cephalosporin, but the penetration ratio is very diverse in this in the same class. And then just now I said that there are probably two compartments when I'm talking about the ELF concentration. However, the truth is there are many sub-compartments when we are talking about ELF concentration, because the antibiotic from A to B, they can actually get dislodged in one, or be trapped in two, or at three, or they can also be in alveolar macrophages. So to say that there is only two compartments in ELF PKPD, I think that it is an oversimplification of the antibiotic concentration in the ELF or in the lungs. And then there are also other additional issues that we need to consider when using ELF to interpret the antibiotic concentration or penetration in the lung. One, we think that the compartment is fully mixed, but I don't. That is probably not the scenario, and we would want the compartment to be devoid of protein, but it is probably not when you're talking about ELF. And the compartment which is ELF represent the infection site only partly, which this is true because when we are talking about chronic infection or complicated infection, the infection is no longer limited to the ELF. For example, in a patient with empyema thoracis or lung abscesses here, you can see the infection is no longer limited in the ELF. It has already spilled into the parenchyma and interstitial tissue. Therefore, the concentration of ELF in this patient will only tell part of the story or part of the concentration of the antibiotic in the lungs. And there are also other issues that we need to consider when assessing or reading papers on ELF. First is the variable BL techniques. I talked to you just now regarding dwelling time. During the procedure, the dwelling time might actually be longer than it needs to be. And the aspiration pressure that is applied to suck out the ELF would actually be varied. And the volume of fluid injected can vary from one patient to another or within a study. And within a study or between studies, there is also a possible variability in terms of the number of BAL aspirate collected. And all this can impact the interpretation of the concentration of antibiotic in the ELF. And there are other variabilities that we need to consider, such as the differing assay methodologies for urea measurement in BAL and blood, and then possible lysis of the cell leading to higher drug level in the ELF, because now we have the concentration of the antibiotic from the intracellular compartment going into ELF, and that will also be measured. So taking all that together, the question is that, is ELF the best method to characterize the antibiotic concentration? Well, the ELF is measurable, and it likely a better predictor of drug activity compared to the serum concentration. And when we use serum level to predict ELF, usually it predicts the level of antibiotic poorly. In a paper that was published a few days ago, it showed that if we were to actually give patient meropenem and use the plasma concentration to predict ELF, it overestimate, or plasma levels overestimate ELF target attainment in up to 30% of the patients. So 1 in 3 patients will have wrong estimation of the ELF concentration if we were to just base on plasma concentration. And finally, when reading papers on the PK or intrapulmonary antibiotic pharmacokinetics, there are a few other things that we need to consider. I think we need to consider the fact that these models are all complicated. Can be complicated, and the way that we look at this, we need to actually understand that model in animals, healthy individual, and sick patient are different. The estimate of ELF penetration in animal models and human models likely not comparable. And what about if we were to actually bridge the data from healthy individual to sick patient? Are the estimate of ELF penetration in healthy adults are comparable to patients? I don't think so. There will be more variability in patient compared to healthy individual. And finally, when we talk about patients and the model that we derive from patients, there is always this question of how many patients are required to get a robust estimate of central tendencies such as median and mean, what extent of variability is present in sick patient, and we do not have much information currently on how phase 1 patient predict drug behavior in other patients with pneumonia in front of us. So with that, we need to actually navigate the data that we have when we read papers on PK or pharmacokinetic data on in patients with pneumonia. So in summary, each sampling site has its own set of limitations, and in pneumonia, ELF might be a good representation for uncomplicated pneumonia. But when we talk about complicated pneumonia like lung abscesses, ELF might not be the only sampling site that we need to think about. We need to have an accurate understanding of the methodology and strict adherence to the BAL or mini-BAL procedure if we were to do the studies on ELF antibiotic concentration. And the interpretation of the data should also consider the underlying host or population for which this model and studies are derived from. With that, I thank you.
Thank you. That was fantastic. We'll come back to questions at the end.